Wonderful. Thank you very much, Simone. And I will say that as really excellent academics, they also were very much in the trenches working closely with civil society on implementation of SSB and other kinds of things, and working closely with government. So a fantastic example of real challenges and real dedication to dealing with those challenges. So I'd next like to introduce to you someone who I think is familiar to many of the members of the roundtable, certainly, and others, Dr. Shiriki Kumanyika, Emeritus Professor of Epidemiology. Here you are, Shiriki, at the University of Pennsylvania, and research professor in the Department of Community Health and Prevention at Drexel University as well, a member of the Roundtable and Planning Committee member for this workshop. And Shiriki will talk about common threads in obesity risk in racial, ethnic, and migrant minority populations. Thank you.
Good afternoon. So I am very pleased to be able to challenge your thinking about some of the challenges. I'll put it that way, and you'll see what I mean as I go forward. My perspective on this is a health inequities perspective. So we know the obesity epidemic is a major threat to population health, and we also know that racial ethnic minority status is associated with higher risk. We've seen data showing that in not just in countries like the U.S. where we talk about racial ethnic minorities, but in countries where racial ethnic minorities are referred to as migrants. And that is essentially talking about racial ethnic minorities, but for a lot of reasons, the migration factor tends to drive the framing. So I've thought for some time in a paper that I did with some colleagues back in 2012 that if we could examine these patterns more closely, we might be able to figure out something from a theoretical perspective, also looking at data, and get some questions and answers about solutions. So I have an updated version of this, my thinking on this. It's under review based on a presentation at a conference in May in Edinburgh called the First World Congress on Migration, Ethnicity, Race, and Health, that was designed to bring the streams of scholarship on race and ethnicity and health inequities together with the migrant scholars who are actually in two different communities and sometimes don't speak the same language and work together. So the causes we've heard about, this is just to contextualize the presentation and so it can stand alone when it's disseminated. But we know that we have a lot of environmental factors that govern the obesity epidemic, these drivers that make it hard for people to maintain their weight. And so the topic here is, why do these factors operate differently in populations of color around the world in high-income countries? So I'm going to show you some data, again, to contextualize this presentation, but I'm going to go through it quickly because I want to get to the sort of thought part of this in terms of the why. So these are U.S. data. I'm going to show you data mostly for adults, but this slide has children on it. And you can see here in that the second and fourth bars are for black, non-Hispanic blacks and for Hispanics, and it's kind of like 50% versus 40% of obesity. This is all BMI 30 overall, and then if you look at the women, it's highest in the women. In non-Hispanic black women, it's about 55%, and in Hispanic women, it's 51%. And you see a similar pattern in the children with more higher risk in the girls, but also in the Mexican or Hispanic boys. I think that the data it said Hispanics, I think most of them are still Mexican American populations. So we have high rates in minority populations, and that's actually where I started this journey, first seeing this in black populations in America, and then noticing that it was also in Latino populations, and other populations, and then noticing that it was the same circumstance in other countries like the U.S. This is the self-reported data for the U.S., and I just include put this to be able to include the data for American Indians and Alaska Natives and for Native Hawaiians and Pacific Islanders, so you can see that the higher rates, self-reported data, are about 10 percentage points lower than the measured data. And the Asian data I don't have to explain because that's been eloquently explained to you this morning, that if you use the BMI cutoff of 30, you will get an answer that's misleading in terms of health risk. So it does worry me that the U.S., that we're still using this without even a footnote, because it gives the impression that this group that needs attention on obesity-related risk factors is just doing beautifully because it's the white reference population and they've got a third of the obesity. So we need to, there is a Screen at 23 campaign in the U.S. that's trying to address this, but we have a long way to go in the way we report on national statistics. This is data from the UK, from Public Health England. And they have this white, Irish, Indian, Pakistani, Bangladeshi, and black African and black Caribbean. And the most outstanding high risk here is in Pakistani women and the women of African descent, African and Caribbean. Again, the South Asians are, this is all BMI 30 data, so you'd really have to rewrite these data to understand what is actually going on in that group. And this is from the Helios study that was presented by Dr. Meeks earlier, and it shows the differences in the different groups, the African descent population in Suriname, South Asian, Surinamese, and so another Western country, the Dutch being low, and all of these are significantly higher than in the Dutch population. Indigenous populations, wherever I've seen data and in a comprehensive review that's been done, in high-income westernized countries have higher obesity, sometimes much higher. So you can see data here from Australia. These are the National Health Survey data, but it's hard, separate from the Aboriginal and Torres Strait Islander survey, but this comparison was presented in a report. And again, you can see the higher rates, and the blue bars are the Aboriginal and Torres Strait Islander populations. And in New Zealand, it's a comparison by gender, the Europeans or the white population at the left, and then the Maoris, the Pacific Islanders, and again the Asians, showing a low rate using BMI 30. So what's the story that you get from this? You see higher prevalence in minority populations of color relative to reference or host populations, especially in women. So you've heard that this morning. I reinforce that. I didn't try to go into children, partly because the data on children are almost an order of magnitude more complex, because you have growth, you have gestational exposures, and then children's own exposures are different. And so this also needs to be looked at in children, but it's really much more complicated, including the age of migration and so forth in children. So the items that are not highlighted in red are for things I haven't shown you, although you have seen data on that this morning. That I don't know if you've seen data on studies of weight gain over time, but there are studies with longitudinal data in migrants showing that if they come in at initially lower weights as healthier migrants from their home country, and there may even be a bias towards people who are healthier migrating, they gain weight over time. This is sometimes called acculturation, or it's studied as duration of residence in the host country. And then the cross-national studies within groups show the effects of Western environments. And this data has been critical to refute the idea of default genetic explanations. Once you see that people with the same general genetic background are having more weight when they are in a different circumstance, then you can say, well, there's got to be something else going on. So I think the environmental explanations have really now taken priority. The classic studies on this were from comparing Pima Indians in the US with Pima Indians in Mexico, and showing that it wasn't something about Pima Indians that just caused them to have a lot of obesity and diabetes. And there have been other comparisons as well. And then the effects of national context you saw in the comparisons about this with the same people living in Berlin and Amsterdam and in the UK. So, what's the reason for this? You might have an explanation in your head. A lot of the things that we think are a part of the issue are part of the issue, but the question is, how does the story fit together? So what's different about minority populations of color compared to the host or reference populations? That's one big question. And then the other is what's similar in these different societies as it relates to minority populations of color. So even though the rates may be lower across countries, they tend to be higher, not uniformly, but they tend to be higher in the population of color that it's been found repeatedly in different groups. So I'll pause and just talk a little bit about the whole idea of race and ethnicity and collecting data on this. In the U.S., well, first I'll say it's when you collect data on something, it implies that it's important to society. It's important for policy making or something else. When I was first involved in 1985 in the report of the Task Force on Black and Minority Health, even the name of that report gives something away. At first it started out to be a report on Black Americans because they were the minority group of interest. Along the way, people discovered that there were Hispanic Latino populations, and they changed the name of the report to expand it and include American Indians and so forth. But they weren't even collecting identifier data on the Hispanic population, and so people were really scrambling at that time to say something about the Hispanic population, which had become of policy interest, and the people in the government had to catch up with that. In the U.S., the word race and racial classifications take priority. That is not the case in Europe. Ethnicity is used as the preferred term. And there is a very interesting literature that will not pop up in PubMed, but if you go to literature on some of the demography literature or in social science, if you're not familiar with it, you can find out why in Europe the color blindness was considered to be so important to protect people, to not collect identifiers about race and ethnicity, because in those registries, the population registries and so forth, people could be identified, and you know the story. So there had been a reluctance to collect this kind of data, and now there has been a movement to collect these identifiers because they are very important for health policy and for figuring out what's going on with the population. So you'll notice in the European literature that socioeconomic status, Michael Marmot's gradient, social class is the preferred variable for health inequities. And a lot of the things where you could learn a lot about obesity, it's all framed in terms of social class. So ethnicity is coming back in, and then migrant data are there, but migrant data are called migrant data. And if people are identified by country of origin, it doesn't necessarily tell you that you're dealing with health inequities, even though the populations are generally marginalized in some ways. I included this slide from the report on ending childhood obesity because to make a couple of points. One is that these socioeconomic status risks are different in low and middle income countries and high income countries, and the expectation is that in high income countries the lower socioeconomic groups will be at the greatest risk. So that's one point. That does not take care of, so to speak, the racial and migrant differences. The patterns are very mixed with socioeconomic status, even though it's a factor. And then the point that I really wanted to make here is the last few words that are not in red. So pointing out that there are subgroups in populations that are at higher risk due to rapid acculturation and poor access to public health information. So there's the answer according to this particular analysis. Surely something called rapid acculturation and poor access to public health information are a part of the story. But is that the why? that the environmental factors are operating differently in these populations. So I have two slides that are kind of wordy, but I hope you can get through them. And then I want to spend the last few slides on showing you the framework that I drew. Anybody who knows me knows that everything I do ends up with some sort of a picture, a diagram. So these are slides about influences. What can be some of the influences on obesity in minority populations of color? So I'm now including the migrant populations as well as the transplanted or long-standing migrants in countries that have been there for a while. So these, some of the, particularly the societal level variables, what's happening in the society. So the racial ethnic category, whether it's explicit or implicit, really boils down to populations not being white. And this is not a pleasant conversation. It's not a conversation I like to have, but it's undeniable that that's a variable. All the populations, even if religion is the major reason for the ism or some other bias, the populations that we're talking about are different from other migrants in that they will be considered others or othered because of their skin color, and it's not hard to document that in the literature that that's what's going on, but it's called race ethnicity. And so what does it mean in terms of possible causation or the causes of the causes? Some of the contextual factors associated with these categories are the food preferences and what happens to the food preferences of the group, the target marketing of unhealthy foods, which happens within the U.S., and Simone was just talking about the target marketing of the low-income populations in Mexico. It may mean a problem with mobility and freedom of movement because you look different. And you can be seen, Canadians have an interesting term, it's called visible minorities. So it's your skin color or it's something you're wearing or something about you that identifies you as the other. And then there's historical and ongoing trauma, and one can never forget that because for indigenous populations, this is permanent, especially for indigenous populations, to some extent for enslaved or other oppressed populations. Socioeconomic status and social position are part of the picture, although they don't explain everything, and I've just listed there some of the variables related to socioeconomic status, neighborhood access, and I could have put schools there. I was very surprised to see, because I go to the Netherlands fairly frequently, I was very surprised to see a newspaper article about segregation in black schools in Amsterdam. And that's what it said in the article, because one way or another, neighborhoods tend to affect where people cluster and go to school. And this article was just saying outright that now, because a lot of African Surinamese were going to certain schools, that's who a large part of the population, it may have also been Ghanaians, but the schools were beginning to be sort of branded as black schools. And I was very sad to see that because it just, I thought, boy, there's something in us that causes us to interpret things in a way that divides. And then there's the migration and the migration stress. And I don't think I need to spend any time in this day and age talking about what that might be. You don't just end up on the corner in the grocery store buying something after you've been, as just like the person next to you, if what you've been through before you left your home, after you get here, what you've lost by not having your home that you may never see again, and then what might happen to you when you get to the doorstep of a country that may have very, very hostile migration policies. So those are some of the things that affect populations of color that are societally driven and then condition some of the context for weight control. And then here are some other variables: the language, the literacy, which can be marginalizing, or it can help if you speak the same language with integration, education, and then the positives that people bring with them that might explain why in some ethnic groups there's less, why the patterns aren't consistent, because some groups may bring with them, the sub-ethnic groups, that don't show the same pattern protections that endure. But the ability to be resilient, to survive things that may be are very adverse. And then I put the stress in yellow because I didn't put stress in every box, but a lot of this boils down to accumulative exposure and continuing exposure to stress. And I just point out to you, the American Psychological Association has a very good report on stress and health disparities. I recommend it, and they talk about all the different pathways whereby stress could influence eating behavior and response to environment, sleep behavior, and so forth. So I have no minutes left, and I'm going to describe this very quickly, this diagram. So these are determinants of obesity, and I've already told you about the context for populations of color that might include the things that are in yellow. The stress literature will talk about the embodiment and some of the physiological reactions that people are changed biologically. It could be epigenetic. And then there's health care, if that's there, to mitigate some of the effects of obesity-related diseases. The exposure to obesity-related risks and the vulnerability to these risks are two parts of the coin. You may have more exposure to marketing of unhealthy food, and you may be more susceptible to wanting that food because of some meaning it has to you. So that leads to the diseases. If you have health care, you may have some mitigation of the consequences. If not, then you will have a higher rate or a higher burden. So on the left-hand side, and this is influenced by the WHO Commission on Social Determinants of Health, you have the national level context that affect the level of obesity, say, in that country, which varies. But that national context also affects the isms, the types of social stratification. And so I'm proposing that there's really an intersection between race and ethnicity and migrant status and any other stratification variables that apply in that country. And some of this stratification depends on the economics, the political system, and so forth. So in the WHO framework for health equity, the things at the left, the context and the basis for social stratification, those are actually the social determinants of health inequities that then condition the social determinants of health. So what determines inequities are not the same as what determines the health, because one is really acting on the same behaviors and contexts that affect everyone, but it then says, why do some people have more of these adverse contexts than others? So my final slide is, in conclusion, obesity is more prevalent, race, ethnicity, and migration intersect. Studying this pattern may give us new insights, especially from a theoretical perspective, and then using the data from these studies, which have a rich database, to begin to describe this. For example, the Helios study is studying discrimination as a factor in the obesity causation. And so my challenge to you in terms of the thinking is that if the pathways arise solely or in part from social stratification, then the ultimate solutions to this excess risk in populations of color requires a major disruption in the isms that get us where we are today. Thank you.